Alright class, so today's lecture is on the spine, abdomen, and thorax. We're just going to go over some key points. So the first slide here just talks about organ referral patterns. So these are all just um, different points in the body where a patient or an athlete may feel pain after they've been struck on the abdomen, or they've landed on their abdomen, depending on what the potential injury could be. So for example, the liver will refer pain to the right shoulder blade region, spleen to the left deltoid, the appendix. This is not necessarily from a direct hit there or anything. This could be if they have appendicitis. They're going to have pain at McBurney's point, which is about a third of the way between your ASIS and the umbilicus. So if you just drew a straight line from there, about a third of the way up is McBurney's point. And usually to test that, you test for pain on rebound. So if you press down on that spot, it may not be painful when you press down, but once you let go, that's usually what causes the pain, and that's a good indicator that there's a problem with the appendix. Stomach, if there's any issues with the stomach, any kind of direct um, hit to the stomach, or a laceration or something like that, the referral point will be in the center of the chest near the xiphoid process. Kidneys will refer pain to the same side of the kidney that's hurt on the low back. And like it says, referred pain will be reported as dull, achy pain that is different or weird. And obviously, if you saw the injury, if it's a football player and they got struck right in the abdomen, these are all things that should be going through your mind as you see that injury occur. One of the other aspects to look at when dealing with a direct blow to the abdomen, or the trunk of the body, is obviously a rib fracture or contusion that is obviously going to cause pain. So that you definitely want to keep in mind as you're doing your evaluation. Next is intervertebral disc. So here we just talk about the importance of them. So one, they're good for shock absorption. They're good for increasing range of motion. They act as a ball bearing, so they increase flexion, extension, side flexion. And third, they also provide lubrication for the spine. One of the other things to look at is the fiber alignment of the annulus fibrosus. So make sure that you read up about the intervertebral disc in your book, so that you know what the annulus fibrosus is. So the fibers that make up that are in a ring fashion. So anytime that there's rotation, certain fibers are going to be put on stretch and others are going to be contracted. So anytime you have rotation or extreme rotation, this is going to be one of the things that could be placed in danger. And the last bullet point says pain originating from disc itself will present in a rectangular pattern across the back at the level of the disc injury. So for example, if they're having pain at L4, L5 of the lumbar spine, typically they're gonna, when you ask them to point where their pain is, they're gonna say it's across their back. They're gonna make like a rectangular shape with their fingers, and they're gonna say it hurts all across my low back. Okay, next we'll work our way up from the lumbar spine. We'll go through all the vertebrae. So the lumbar spine, like it says, is the largest vertebrae in mass due to weight-bearing status. So a lot of your body weight is going to be transmitted down through your spine, and most of it is going to be carried by your lumbar vertebrae. It says a neutral spine can withstand 10 times the forces it would out of a neutral position. So for example, if your spine is not bent over, is not an extension, is just straight, you can put 10 times the weight that you normally can if you are in slight flexion. So that's why it's important that your athletes have some sort of core stabilization exercises in order to prevent, because they're probably going to be the same exercises you're going to be doing if they hurt their lumbar spine or any part of the spine for that matter. So the small muscles that stabilize the spine, so all the muscles that are used to brace, to basically tighten up your stomach, those are the muscles that are going to be important to train, because it's not just, okay, can I do a bunch of sit-ups or, back extensions, deadlifts, things like that. It's not about so much the intensity or how much weight you're doing with a certain exercise. It's also the timing. If you don't know, if your patient, your athlete, isn't firing those muscles to stabilize the spine at the correct time, it doesn't matter how strong they are. So we'll kind of elaborate a little bit more on that. It says there are several muscles that act on the pelvis and lumbar spine that may affect spinal alignment. So, for example, hip flexors, gluteals. These are some of the muscles that you're gonna hear a little bit more about, because they, anytime someone has tight hip flexors, okay, that's what's, giving you a an anterior pelvic tilt. So that's going to be putting a lot of more stress on your low back. And also tight gluteals, which could give you a posterior pelvic tilt. So aside from strengthening, there's also some muscles that you want to make sure that you're keeping flexible. Okay, so next we talk about the thoracic spine. This is the most stable portion of the spine. There's very little movement within these thoracic vertebrae. You don't get a ton of rotation specifically, as much as the cervical spine or the lumbar spine. The thoracic spine does very little rotation, but it is important. I mean, you do need a very small degree of rotation from each thoracic spine, each thoracic vertebrae. Otherwise, you're going to notice that your athlete is not going to make a full turn, or maybe in one direction they can and the other they can't. It primarily flexes and extends. So this is where we see some of the use for it, but it's still very minimal. But importantly, it says that thoracic spine extension is required for end range shoulder flexion and abduction. So every time that you move your arm into flexion or abduction, the thoracic spine is going to go into slight extension. So you need that extension. If for some reason it's blocked, it's not moving in that direction, then you're going to struggle a little bit more with shoulder flexion and abduction. The next thing we want to talk about is the ribs. The first 10 ribs are going to have articulations with thoracic spine at the facet joint. So the importance of this is that anytime you have athletes that are lifting weight, that are rotating, that are, doing throwing movements, anything like that, it can put one of these ribs out of place from that facet joint. It can be stuck in a position where it's not allowing the athlete to rotate to a certain direction. They're going to feel pain right at that vertebro-costal junction, or costal vertebral junction, and that's going to be in their back. So it's going to feel a little bit different than normal back pain. They're going to say it's a kind of a sharp pain. They're going to have trouble breathing. Usually that's one of the more common things that they state. Sometimes it could be as bad as where the patient says that they're having a heart attack. It feels like the pain is radiating towards their chest. And obviously you want to take that into consideration, but if you know the mechanism that caused this pain, you're going to keep the heart attack portion in the back of your mind, but for the most part, you're going to be treating this as like a rib subluxation. Okay, so finally we get to the cervical spine. And here, anytime that we're dealing with an athlete that is complaining of pain in any portion of their cervical spine, we want to make sure that we take the time to really evaluate the athlete or the patient. We want to make sure that there's no deformities, that there's no radiating pain down their arms or fingers, anything like that. And obviously, if this is an acute injury, so let's say they're on the field and you saw that they got hit on their neck, or their head has some sort of whiplash motion, you're not going to be moving this athlete. You're going to be palpating, you're going to be evaluating this patient however you found them. You don't want to be moving them. So, like it says here, there is no intervertebral disc in between the occiput and C1 and between C1 and C2. So there's no cushion between the base of their skull and the first cervical vertebrae, and between the first vertebrae and the second one as well. So it says C2 is the first palpable spinous process. So this is just for palpation purposes. As you're evaluating the athlete and you're putting your fingers along the spine, the first vertebrae that you're going to feel below the base of the skull is going to be C2. So what I want to show you now is a video. Since this week your assignment has to do with CrossFit and working out and people working out at the gym, I just want to show this quick video of a CrossFit lift, and this just occurred this weekend, this lift here. So let's just watch really quick. Okay, I'm going to forward this a little bit because I want to watch this. Okay, so just looking at those lifts, the clean and jerk, you can see the load that they're putting on their spine as they catch the weight, and then they have to press it from their chest above their head. And just talking about the spine and the importance of stabilizing the spine, you can kind of see that any slight wrong movement by any of these athletes can put them in a big risk of herniating a disc, of straining a muscle, and potentially dropping that weight on their body as well. Okay, so the next slide I want to talk about is this Canadian C-spine rules. So in Canada, almost anyone can be seen for an injury or a sickness. So what they've done to make it more efficient is to know when more diagnostics are warranted. So X-rays are indicated if any of the following are present. So anytime you're a patient and you have any one of these aspects, then you will probably get an X-ray. Now this is a lot different than here in the United States, where a lot of it depends on your insurance. Your insurance kind of dictates what kind of treatment you get and what kind of diagnostics you get as well, which could be, it's concerning, and it can make your job more difficult because you want to make sure that your athlete and that your patient gets the best care possible. And there are times when you're going to have to do a lot of work with insurances. You're going to have to make sure that you have the proper information, that you're communicating between the physician, the insurances, and the patient. Making sure that you're giving the proper information to each of those parties. Okay, on this slide we talk about the different spondies. So you usually hear a lot of doctors, physical therapists, athletic trainers say, "Oh, that athlete has a spondee." So depending on what the actual injury is, they may be referring to one of these three pathologies: spondylosis, spondylolysis, spondylolisthesis. The first one is just degeneration of the vertebrae, or multiple levels. the spondylolysis is a fracture on the pars interarticularis. So it would be just one side of on the vertebrae here. And finally, the spondylolisthesis is a bilateral fracture, so two fractures here, and that would allow the vertebrae, the whole body of the vertebrae, to actually translate anteriorly. So that can be very dangerous. And anytime there's a certain injury that dictates an X-ray. So, for example, like we just watched that clean and jerk at the CrossFit Games. If there's enough weight to create a fracture at the vertebrae, or let's say someone got hit from behind and right on the spinal column, then that's something that they're going to need to go get X-rays. And even before the doctor sees the X-rays or does the X-rays, these are some of the things that you want to just make sure that you're aware of. And it says these pathologies occur in athletes who are prone to extension activity. So obviously all of our football players, anybody who's doing any kind of lifting. So if, like we just saw, our CrossFit athletes, anytime the athletes are getting put into extension or are doing extension exercises with a lot of weight, they're going to be at risk for this as well. Okay, the next few pathologies we'll talk about is stenosis and then also a protruding disc. So stenosis is the word just basically means a narrowing of a space. So in this case, we're talking about narrowing of the foraminal space, where it's to the point where it starts pinching on your nerve roots here. So this can be due to a bone growth, and it'll start decreasing the space that nerve root has. The other problem could be due to a disc degeneration. So if you look at the intervertebral disc here compared to this one here, this one is a lot smaller, it's shrunken a lot. So you can see this happening a lot in older adults, and that's going to limit the amount of space that they have for this nerve root as well. The next is our disc bulge. And as you can see here, we have different severities of a disc bulge. You can start from prolapse to extrusion and eventually to sequestration. And this is when the nucleus pulposus can actually come out of the disc. Okay, our next slide talks about sensitivity and the type of pathology. So usually when you have an athlete who's having back pain, you want to start with exercises that begin away from the sensitivity and slowly progress towards that motion. So obviously you're going to do your evaluation, you're going to find out what's causing that pain. You may need to do x-rays and MRIs and all that. But once it's time for them to start the rehab, you're going to start them with exercises that go away from whatever's causing their pain. So if they're having pain with bending over, with trunk flexion, then you're going to start with exercises that go or puts them into extension. And that's usually because if there's a disc problem, let's say the disc is bulging anteriorly, that means that extension exercises are going to aggravate that problem. So you'd want to have them into or start having them do flexion exercises. So here's just some general ideas about being flexion sensitive and extension sensitive. So flexion sensitive usually due to disc herniation, but it could also be a facet dysfunction. Extension sensitive may be due to a facet dysfunction, but then also, if you can see here, it's all the spondy pathologies. Okay, and finally we get to our exercises. So for lumbar stability, here are a few exercises that we typically have our athletes do. And again, like I mentioned before, we're trying to make sure that the small muscles that stabilize the spine, specifically the lumbar spine, are firing correctly and that they're firing at the right time. So usually we start our athletes with very simple bracing exercises. So we have them feel the sensation of bracing. So when you lay down on your back, you usually have a small arch in your low back, in the lumbar spine. When you brace, when you activate those core muscles, that arch flattens out. So that's the sensation we need our patients to really know what it feels like. Once they've got that down, then we can start adding motion or actual movements as they're bracing. So all these exercises that are shown here begin with this bracing activity. They first have to brace and then they can begin the exercises. Posture exercises, basically just to make sure that the athletes aren't putting themselves at more risk by having round shoulders or that their neck is always in flexion. Um, that's typically what you see, especially people that are sitting in front of a computer all day and that they're typing. Their shoulders really rounded, their neck is very flexed. So these are all exercises to train the rhomboids, the trapezius muscles, specifically the lower traps, posterior deltoids. These are all exercises that will keep your thoracic and cervical spine in a more neutral position. All right, and that's going to be it for this week. If you have any questions, please post questions on the discussion board or you can email me as well.